I'm going to talk about the economics of medical care. This is an area in which, as we all know, there has been a trend toward ever greater government involvement. The spending for the provision of medical care inevitably leads to control over the fees that are charged for medical care. And it should. If government is going to spend money, it ought to be concerned with what it pays for what it gets. Control over fees inevitably leads to control over the practices that are followed, over the behavior of the medical personnel. And if this trend continues, it inevitably leads to completely socialized medicine. I believe that this trend, including many of the steps that have already been taken, is very much against the interests of patients, of physicians, and of other healthcare personnel. And in the brief time I have available today, I want to explain why I believe the trend is so much against their interests, why it has occurred, and what, if anything, can be done about it. The trend toward increasing government involvement in health care is not an isolated phenomenon. It is not restricted to health care. It is part of a general trend in our society toward replacing voluntary free market arrangements by government control and regulation. It is a trend that is happening all over. It has happened in one industry after another. There is nothing special in this respect about the move to replacing private voluntary medical arrangements with compulsory governmental arrangements. This movement in the medical care field is not special in another sense. In industry after industry, producers who protest most strongly their belief in free markets have fostered and helped produce government takeover, government regulation, government control. To begin with, a greater involvement of government in medicine may seem to serve the interests of at least the purveyors of medical care by providing an additional source of finance. This is a honey that has led persons in industry after industry to support and promote governmental involvement, which has reacted ultimately against them. I have been impressed again and again with how often businessmen, leaders in various areas, who are very farsighted when it comes to their own activities and to concerns within their enterprises, are very short-sighted when it comes to the area of public policy, and allow themselves to be led by small advantages to foster and favor policies which ultimately redound very much to their disadvantage. In the medical case, the initial inducement is that here is a new source of money. And presumably this is why organized medicine has been schizophrenic about the trend toward government involvement. It has, on the one hand, tended to protest against the move toward socialized medicine. It has, on the other hand, engaged in activities which have promoted that development. When the government is taking over any activity, there is more money available. But what typically happens is once the government has taken it over, the situation changes. There are no more votes to be gotten by taking it over some more. You have to move on to new fields and take over new areas in order to get some new votes. And the result of that is that those areas already taken over get starved. And instead of there being more resources available, there are fewer. In addition to the fact that the ultimate result of a government takeover is less resources, you invariably get lower quality and a lower quantity of medical care. I am going to cite from a study that was made by a British physician, Dr. Max Gammon, who spent 5 years studying the British Health Service. Mr. Gannon, in a rather amusing way, developed what he called a theory of bureaucratic displacement. He argued that whenever you have any organization taken over by a bureaucracy like a government, what tends to happen is that input goes up and output goes down, that useless work tends to displace useful work in a further extension of Parkinson's laws. And he illustrated it with hospital service in the United Kingdom. He took the 8-year period from 1965 to 1973. In that 8-year period, the hospital staff, the number of people, went up 28%. Incidentally, administrative and clerical help went up 41%. But what about output? What about what they were producing? Input was up. Well, he measured output by the average number of beds occupied daily. It turned out that the average number of beds occupied daily went down by 11%. And he hastened to go on to explain that the decline in the average number of beds occupied was not for want of patients, that at all times there was a waiting list in the neighborhood of 600,000 people waiting for hospital beds. I don't know how many of you know the scandals in Britain about the waiting period for what is regarded as optional or postponable surgery, including, for example, bypass operations for heart problems. There are stories of people who waited 3 years to have a bypass operation because that could be postponed. Indeed, some of them managed to die before the operation was performed. But 600,000 people waiting on the waiting list, and for rather more readily and more obviously postponable operations, the wait may be much longer than 3 years. Let me turn to Sweden. I quote from a report by Dr. Gunnar Bjork. In Minnesota, I should be able to pronounce a Swedish name, but it takes more than physical connection. He's a professor of medicine at the Karolinska Institute. He's the head of the Department of Medicine at a major hospital in Stockholm. He formerly was, and maybe still is, a physician to the King of Sweden. He gave a paper in 1976 at the University of Chicago on, quote, how to be a clinician in a socialist country. And I quote from his paper. It is obvious that the existence of a competing free market constitutes a continuous threat to the operation of a socialist public service, however heavily subsidized by taxpayers' money. The element of quality that derives from patients' personal preference for and confidence in certain doctors cannot easily be done away with so long as people are willing to pay for a free choice of physicians. To do away with such opportunities, therefore, has become a new goal of Swedish healthcare politicians. The introduction of these various regulatory processes has resulted in a cancerous growth in the numbers of medical administrators at all levels of incompetence. The Board of Welfare, I go on quoting, has recently issued a 60-page book trying to describe how to calculate the number of physicians needed to cover the necessary staff of any one clinical department. The book is a fascinating monument over the total absurdity into which legislators, administrators, and trade union representatives have finally brought a previously simple and efficient machinery. The setting in which medicine has been practiced during thousands of years has been one in which the patient has been the client and employer of the physician. Today, the state, in one manifestation or the other, claims to be the employer, and thus the one to prescribe the conditions under which the physician has to carry out his work. These conditions may not, and will eventually not, be restricted to working hours, salaries, and certified drugs. They may invade the whole territory of the patient-physician relationship. If the battle of today is not fought and not won, there will be no battle to fight tomorrow.